and express our gratitude to Christina King. Don't know what we have to do officially, write her a letter allowing her to go. But anyway, I would nominate Linda Viera to assume that position.
Do I have a second?
Second.
Thank you very, very much. So just raise your hands if you approve of that nomination. Okay. Hey, John, I see, since John is here, does this, can we go ahead and appoint her, or does it have to go to the BOCC?
Sorry about that. No, the recommendation for appointment goes to the BOCC and then they make it official.
Okay, we will so proceed. She's very highly supported, a very active member of this board. So if you can take that forward, Karen, to the BOCC, that would be wonderful for the next meeting. Thank you.
Marky, sorry to interrupt. We're just trying to balance reaching out to Ann Mullen and getting her online here too. But we had Greg for the first. Who was the second?
Tori.
Tori, perfect. Thank you.
Thank you. Okay, Suzuho, we're going to talk about virtual meeting guidelines. Suzuho.
Hey everyone. So I'm really just available here if anyone has any questions. I can also go through a basic tutorial if that would be helpful as we switch to this webinar format. Does anyone have any questions about how you logged on or how you mute and unmute yourself, raise your hand, things like that? Okay, and just to help us take minutes here, Lindsay's kind of visually scanning for hands that are being raised when we do a vote. So if you are screen sharing, if you can make sure you take the screen down so that we're able to see everyone quickly and move on to the next agenda item, that would be great. Thank you.
Thank you. You know, we're all going to be pros one of these days on Zoom. Tell you the truth, I'd like to be in person with all of you. Just saying. Okay. Next agenda item is going to be Charlie, I think. Correct?
I think so.
Yep. Charlie, how are you?
I'm doing great. How are you doing?
I think everybody's doing fine, but we're sick and tired of Zoom.
I'm getting better at it, I think.
I've declared we're all pros now. But Charlie, give us some update on all the data, and then I'm going to be asking Karen to talk about the new orders a little bit and what we can anticipate, and that'll be in the roadmap for reopening. So Charlie, tell us how good we're doing.
And you have my slides now, right? My big slide. All right, perfect. So as usual, I always want to start with a little bit of a story from history. This one's about super spreading, contact tracing, and the ethics of revoking a person's civil liberties in the interest of public health. Most of you have heard the name Typhoid Mary before, but most people don't know that it was a real person. Her name was Mary Mallon, and she was an Irish immigrant and a cook for wealthy families in Oyster Bay, which you might have heard of. It was the home of Teddy Roosevelt. Her specialty was peach ice cream with cut up peaches, but unfortunately her other specialty was not hand washing. She was an asymptomatic spreader of Salmonella typhi, the causative agent of Salmonella typhoid fever, but she didn't really know it. So in 1906, it resulted in a cluster of 22 typhoid fever cases and 1 death. And a sanitary engineer was brought in to do the contact tracing and case investigation. And he found the common denominator was not water or tainted shellfish. It was this cook, Mary Mallon. So she was isolated on North Brother Island on the East River off the coast of the Bronx for about 3 years, and was released only after she promised not to go back to cooking. And soon thereafter, there was another cluster of 25 cases and 2 deaths at the Sloan Maternity Hospital in Manhattan. And it turned out the cook was Mary again. She had changed her name to Mary Brown and taken the new job. So she was rearrested and returned to North Brother Island, where she spent the rest of her life in quarantine, and all over about 26 years. She wasn't the most prolific spreader of her time, nor the most deadly, but she was one of the first identified asymptomatic spreaders, which is something that we're now seeing with coronavirus. And she probably also suffered a little bit of prejudice of being an unmarried Irish domestic servant. And we are obviously seeing some implications of people's living situations affecting their coronavirus as well. So how does that translate into today? We have identified these super spreaders in Chicago. There was one person who had mild respiratory symptoms, went to a family dinner, a funeral, and a birthday party, and it resulted in 16 known cases and 3 deaths. In Washington State, there was a choir practice, and that just from one person being at that choir practice led to 52 known cases and 2 deaths. And a bridge club in Colorado Springs that led to 25 known cases and 4 deaths, and seated infections in senior care centers throughout Colorado. So what all these events have in common, and what are the risks now of as we reopen and the mass gatherings we're seeing maybe even in the news today? What we're recognizing in the commonality in these outbreaks is the majority have been indoors with people closely spaced together and with lots of talking, singing, or yelling or talking above the din of noise of their environment. Outbreaks from retail stores and outdoor environments have appeared less frequently. And as the experts have looked at this, what they've seen is that as few as 1,000 viral particles are necessary for an infectious dose. Speaking face-to-face across from somebody releases about 200 particles per minute. And not all of those affect the other person, some of them fall away. So contact tracers now are using, if you talk face-to-face to somebody for any more than 15 minutes, you're considered a contact. So we can use some of that information and data to think about the kinds of environments where transmission may occur in the future in these environments that we're opening up. The School of Public Health and CDPHE have produced some new studies, new modeling to look at what kinds of things are going to be important in the future to avoid super spreading as we open up and spend less hours at home, gather more in parks and on trails, at restaurants, stores, lodging, and at events. And in this graph, what you see is the horizontal line, the current capacity in Colorado is to do case investigation and contact tracing for about 500 cases a day. If the population as a whole socially distance at 65% or less or more, we can avoid things getting out of control. But what we've determined is, as we open, what's really going to be important is a continuation of the 5 commitments for containment. It's going to wearing masks, getting tested as soon as symptoms are felt, socially distancing are going to be very important going forward. And the more we do that, the less problem we're going to have in opening up. this modeling is based on everybody socially distancing at greater than 65%, which means in practice that you limit your social interactions to less than 65% of your pre-COVID activity level. So if you think about what you used to do before COVID, how many people you shook hands with, you hugged, you talked face-to-face for more than 15 minutes, you want to reduce that level by 65%. And the model that if we go back to the model, the line that the gray line that goes up the most steep is based on people that are over 60 years old socially distancing less. We really need people over 60 to socially continue the 5 commitments at over 80% to keep the capacity below what our hospital beds and ICU beds are. So even as we open up, we need to think about these things and messaging to the public that it's still important to do all of these things. CDPHE's modeling indicates possibly that the next wave would be in August and maybe with a peak higher than in April. So they're really worried about in their models that people are not socially distancing. And of course, you watch the news at night, you see a lot of that going on. So we're monitoring a lot of data points, but I wanted to focus on 2 thresholds that were called out by CDPHE in granting our variance. And you might have read that in the letter that we received. They called out that if our COVID case count goes above 18 per week, or our positivity rate for PCR testing goes over 10%, they're going to be concerned. These are very specific measures that's of importance to them on a statewide basis, but we believe that monitoring many other factors are important, and we'll be able to have a better understanding of any surge in cases and present that to CDPHE if that situation arises. Our goal would be to focus on individual outbreaks and sectors, followed by slowing or pausing the pace of reopening to stay beneath those levels and avoid having to take steps back at a total population level. So we're going to be monitoring a lot of different data points. So one of the questions is, where can you find out how we're doing relative to these and other measures? You want to go to covid.19.pickenscounty.com/COVID-19-stats, basically the website that has this dashboard. And we'll be putting it out to a lot of different sources so that people can see exactly how we're doing against all of these measures. We're also going to be adding a new graph with positive and negative test results and positivity trends. So you see a little extra room there on the right-hand side, and we'll be adding those. Where we are today, these figures for testing only represent PCR testing at ABH and include testing of staff, pre-op, respiratory tent, emergency department, and community testing. We could be testing more, but we don't have a lot more symptomatic patients. The governor recently set a goal of testing 10,000 people a day in Colorado. But in order to reach that goal, we're going to have to test more asymptomatics in order to get there. To give you I showed you some numbers 2 weeks ago for our testing. At that time, we were at 348 tested and 22 positive. So 2 weeks later now, we've gone up by over 100 tests in that week and only 1 positive test. And that 1 positive test actually turned out to be an asymptomatic pre-op patient at ABH whose symptoms had occurred in early April. So when we look at the next chart that's on the dashboard, talks about confirmed cases by reported onset date. So even that case that we just turned up at ABH, his original onset date was early April. So we haven't seen a lot going through the month of April and May, and even into the start of June. We did have one new case that was reported today, and that one is a case of someone who works in Garfield County and was tested in Garfield County, but lives in Pitkin County. So you will see a new case pop up on this chart, should be popping up tomorrow. But all in all, things are still going pretty well. We're also continuing to look at our syndromic influenza-like illness in the community by asking for everyone to report symptoms, and we're not seeing anything much of it all. There were 4 people that filled out the survey, and we contacted them. All of them had been tested and they were all negative. So again, even on that level, we're not seeing anything. The next chart on here kind of compares us to other counties and making sure that we're talking to them and about anybody that is coming up from Garfield or from Eagle. Our cases here in Pitkin are stable as compared to our 7-day moving average. And last 2 weeks ago, Dr. Kurt asked that we also include, some information on what the cases are per 10,000. Our cases per 10,000 are about 33. Eagle County's cases are actually increasing right now a bit. They have a little bit of an uptick. They have an outbreak in a long-term care facility and several clusters within households. Their cases translate to about 109 cases per 10,000, so about 3 times the rate of our cases. Garfield County, on the other hand, does have a few new cases in some clusters and families that were related to Mother's Day gatherings and a construction business, but their rate per 10,000 is about 25, so it's about the same or a little bit less than ours. And cases in Colorado are decreasing overall, at least at this time, from what the data shows. It'll take another week to 2 weeks to see the effects of Memorial Day weekend and of the mass demonstrations that are going on in Denver. Cases statewide are, at a rate of about 47 per 10,000. So we're doing pretty good in terms of our comparison to adjacent counties and as compared to Denver. And lastly, I wanted to show just a couple other data points. This particular graph starts showing mobility between counties. And the green lines are weekdays, the blue lines are weekends. And you can see that during January, February, and the beginning of March, we had a lot of people coming from our adjacent counties into Pitkin County, and that just fell off in April and is just now starting to come back up in May. That data has been further broken down, and we can actually see which counties people are traveling to Pitkin County. Pre-COVID, that included Denver Front Range, Garfield, and Mesa counties. During the stay-at-home orders, it was just some traffic from Eagle and Garfield and a little bit from Mesa, but the whole Denver Front Range, we didn't see much mobility to Pitkin County, as you would have expected and could have predicted. And last week, we're starting to see a higher level of traffic, but still haven't picked up much from Denver. And this last graph shows kind of in the light green, shows the intra-county movement around, traffic and mobility. And the blue graph above it shows the people coming from other counties. And you can see that during January, February, and March, we had a lot of traffic coming in from those other counties. It fell off to where it was only us moving about here, and now it's starting to pick up again. We're getting more data on airports and building permits and some other measures that we'll be able to present in the future as well. But that's mainly, kind of how things are going from an epidemiology point of view. I want to turn it over to Dr. Levin now, who's going to review kind of the healthcare capacity side of things. As long as I figure out how to get out of here.
Okay, great. Thank you, Charlie. Give me just a second here to pull up one thing.
Yep, I think I'm out.
Are we going to come back with questions for Charlie?
I was going to take a few right now because Greg Postman posted a few questions, and Tori, I think you have your hand up. So go for it, Greg.
Okay, Charlie, thank you for that. The historical thing really helps a lot, I think, to give us some context, and then also the detail you're giving us is really useful. Just regarding the 65%, I'm assuming that means if your social activity is 35% of what it was pre-COVID, then you're in one setting. But then you said something about 80%. And so that means 20% of your former social activity would reflect the desired level of the social activity. That helps me a lot. It's like, okay, I need to reduce my activity by 4/5. In other words, if I'm going to try to maintain that. And I just want to make sure I'm understanding that properly.
That's correct. And, like most models, as we've talked about in the past, it's all based on their mathematical formulas. So they're plugging in these numbers. How that translated into action for all of us is much more difficult. So we ask that question, what does that mean? What's 65 versus 75%? So we tried to get that clarification, and basically you just got to look back at what you were doing before and try and limit those personal interactions and think about how the virus is transmitted in particular, that if you're going to spend a lot of time talking to somebody, it'd be great to be wearing a mask and being 6 feet apart as opposed to being up close and personal.
Great, thank you for that. That really helps.
Kind of follow up on that same thing. So Charlie, I was wondering, the 65% socially distanced, and what we've heard is it when that moves to 45% that we have more likelihood of that transmission? I don't know how that's measured, but if you were to look at Aspen or Pitkin County, where would you say we are?
That's really difficult to measure, other than to say that we're looking at the cases. We're not seeing the transmission. So that either tells us the virus is not present, or we're still doing a good job of socially distancing. As we bring in more people from the outside through the airport or through other counties, there'll be more opportunity for virus to be transmitted. And that's where we can't stop that, because that's where we want to go for our economy. But what we can do is be more cognizant of those socially distancing parameters that we've talked about.
Thank you for that. And you mentioned that there was one new case of a Pitkin County resident that was working in Garfield, I believe you said. Is the contact tracing for that person, that individual, going through Pitkin County or
Yes.
Garfield?
Pitkin. Yeah.
Thank you.
Okay, Kim, are you ready? Okay, she's going to show her slides and she's going to unmute herself.
Okay, thank you. All right, let me show these slides. Can you all see that?
Yep.
Okay, great. So thank you, Charlie. A little bit of overlap, but I wanted to start with presenting the hospital, Aspen Valley Hospital data to again look at the matrix, which is on the dashboard, which is on the Pickens County Public Health website. And looking at our status, we are the same. The hospital is stable. The hospital is in a comfortable position on all three items: inpatient hospitalization, average daily visits, and essential healthcare workers. So we're comfortable. We've been stable for about a month. Again, Charlie mentioned that we have not seen Memorial Day weekend and the recent openings yet, and we will wait at least a couple weeks, 2, 3, 4 weeks for those data to come in. Inpatient hospitalization over the past week, there's been one COVID-like patient, and that patient tested negative. So we've had no COVID patients for the past week who have been inpatients in the hospitals admitted. Essential healthcare workers, there are 2 out right now with COVID-like symptoms. Otherwise, very stable. Our healthcare force is in place. Daily visits to the respiratory tent have been below 10, and to the community testing. It's been between 0 to 8 a day from the 2 of them, with like a mean of 4. So it's been about the same and stable over the past couple weeks. This is the medical patient test results. And again, we started testing April 24th for the community testing, but for the ED, inpatient, and respiratory tent, there's a much higher rate, here we go, as it took off here, a much higher number of testing, and again, a very low number of positive rates. And again, I know Charlie had mentioned positivity rate. So our positivity rate has gotten very low only because our testing numbers have gotten a lot higher. So the denominator's gotten a lot higher. So the rate's gotten lower, and I think it's down to about 5 to 6% and was up at about 14 to 15%. I skipped one. So this is just looks at the number of positive test results at Aspen Valley Hospital. And it just kind of shows that there was a gap in here. And so now we're seeing some positives, and we'll see what we see as we go along with this. This again looks at all testing, the inpatient, the ED, the respiratory tent, the community test, and then pre-op and OB, which we know are asymptomatic. And the numbers have gone way up again in terms of the number of testing that we've done. And then again, the positivity numbers and rate has stayed lower. So these are just all data that shows that we are in the same position. The numbers are low. This is the cumulative rate. So it's going to be an additive rate of the number of tests that we've done. And again, the positivity numbers, the positive numbers. And then Charlie went over this. I think your numbers might be slightly different, but positivity rate of about 5 to 6%, total number tested 418 and climbing. So we are doing we are continuing to test, and we will see how things continue to unroll after the recent openings and our new public health order, and as we continue to open up as we need to do. And I think that, oh, this was the healthcare workers out sick. So again, back in March and April, we had a number of healthcare workers out. Now our workforce is back and we're in full force, and the hospital is in a good position at this point. This seems to be coming up as a theme, and I just wanted to talk about it again, the 5 commitments that these work. I know that these are commitments that each member has in the community. And I just wanted to mention, you know, as we communicate and interact with each other in the community, on sidewalks, in stores, around town, I just wanted to ask people to be kind to each other and to communicate in kind ways, and is a focus on education, so that, you know, there can be a lot of anger that comes out, and interactions can get upsetting, and And I've seen it myself. And I think if we all focus on kindness and in terms of educating each other, and if you see somebody not wearing a mask when you think they should be wearing a mask and that kind of thing, if we all do that together, I think as a group and as a community moving forward, we'll do a lot better. These do work. We know they work, and it's going to be the only way to go through. As we open up, I think we can open up in a way where we can maintain hospital capacity if everybody does these 5 commitments and educates each other on it. And then I just, I think that's my last, okay. Yeah. I'm going to stop this share here. I just wanted to mention, based on that this conversation about kindness and educating each other, that the big elephant in the room today is everything that's gone on in the past week. And in terms of public health and being a board of health today and what's going on in our society, I just wanted to take a moment and honor the death of George Floyd in Minneapolis. And what it ignited is the biggest wave of protests and civil rights activism in our country, widespread. And just how tragic and frightening, and the curfews, the clashes, the protests, the violence, in the midst of all of that. And I just wanted to take a moment. I know we're talking about a completely different topic today, but it's really hard not to mention it and to take a moment of it. That, it's out of all of this, I do see an opportunity for hope. And I think the hope is that people are being awakened and have a voice, and that these peaceful protests, again, of emphasis on peaceful protests and having a voice, and you having your own voice in the community to make things better and to be heard. And there's more energy now than ever to create change. And just, again, looking at racism itself as a public health issue. And as we've seen in this pandemic, it has unfolded that there's racial discrimination. There's that it has unequally affected people of color, the different socioeconomic differences, access to medical care, people who are frontline workers and have to be at work. And so I just wanted to take a moment to acknowledge that. And as a board of health here, that we look at this as an issue that's inextricably intertwined with the pandemic and politics and race, and that we have voices and we have peaceful and powerful voices moving forward against it and towards it. So that I wanted to mention. And then the last thing I wanted to mention was that the University of Colorado and the ECHO series, and I can bring this back up again, has unfolded a lot of data this week. And Charlie mentioned a lot of it, that we think we're at about just under 3% prevalence rate, which really sets us up for a spike. So we're the models and the epidemiologists of the state feel that we're at a very low level of prevalence, which means there's a lot left in the community for this transmission, which sets us up for a spike. And we think that it may be, the modeling is maybe mid-August and again in November, and that these spikes may possibly be higher than what we experienced in March and April. Now there's really a focus looking at the vulnerable population. So the population over 60, 65, people who are immunocompromised, chronic lung and heart disease, diabetes, and then there's others who are at fragile medical conditions that may be deemed in a vulnerable population as well. And so these vulnerable populations are the ones that are going to most likely overrun our healthcare system and our hospital capacity, and that this population needs to be protected, that we all need to do our part to protect this population. And so the estimate of social distancing is that we need to maintain at least 60 to 65% in order to protect them. If we go down to, models have shown that if we go down to 45%, that we will overwhelm our hospital capacity. And it's really hard to gauge, like, what's 65, what's 45. You just do your best in terms of what were you doing pre-COVID, and that percentage of what percentage were you staying at home and interacting with others closely. So I think that's really important to look at. And let's see, I think just that critical point.
Thank you very much, Dr.
That's it. Yeah.
I'm looking to see if there's a question. Anne?
Sorry, took me a second. So Kim, first of all, thank you very much for your comments about the protests and what's going on aside from COVID in the nation. Very well said, very compassionate. So my question, April 27th, we opened to construction. May 9th, we opened limited retail and made some other changes. From the data you've presented, you and Charlie presented, I don't see that there was any spike. Could you comment on that?
Yeah, we have not seen a spike from the opening yet of the opening. So April 24th was it construction and landscaping, and then May 9th we had our first major opening of retail. You know, it may be too early to see what May 9th has shown, and now we're doing kind of compounded openings, and we'll see. You know, I think a lot of it is based on the 5 commitments by everyone, and this is such a brave new world that every day is a new adventure, and we'll see what it brings. I think I think in a few weeks, you know, after this new opening, we may start seeing some more cases. And I know Valley View, they did see a couple of little couple families of spikes, and they did transfer one COVID positive case down to Denver last week. And so we'll see, you know, we expect it. And we just hope everyone does their part. But you're right, we have not seen a spike yet from the May 9th opening.
I was just looking for a little certainty, but I guess there is none. Okay, thank you very much.
Yeah, thank you. One of the, we're going to move on to our next agenda item, that's John. And one of the challenges I think many of us have tried to sort through is what is our role relative to the work of being on the Board of Health. And within that is what is our responsibilities and what degree of decisions can we make? What needs to go to the BOCC and also to including our council people at our local levels, municipal levels. So with that, John and I had a conversation earlier this week, it may have been last Friday, I don't remember, with Karen and Phyllis, which was very, very helpful. So John, would you take the lead here and be prepared for some questions for John? So.
Okay, Marky. Well, in addition to the searching for appropriate roles, the question that I've heard pop up with a couple of different times and in different scenarios is sort of who's in charge, you know, who makes the final decision, who does what kind of thing, apart from the more defined roles. The issue is kind of an interesting one. The state of Colorado through the legislature in 2008 or 9 decided that the existing system was not working. So they redid the Public Health Act at that time and established what is called the Public Health Agency. It was then incumbent upon the individual counties in the state to establish a public health agency in their jurisdiction, and for smaller counties, if they wanted to combine with other counties to have a regional public health agency, then that was acceptable as well. And for some larger municipalities, if they wanted to have a separate Board of Health for themselves, and that was acknowledged also. But for the most part in the state of Colorado, the counties have established public health agencies. So the Board of County Commissioners then, in establishing the agency, following the statute, then establishes 2 different entities within that agency. One is a public health director, so Karen, and the other is the Board of Health for the jurisdiction for each county. So each Board of Health in the state acts within a political defined area of the county boundary. So the Board of Health, once identified and once its composition is established, the individual members are appointed Board of County Commissioners for each county. That's pretty much it at that point then for the Board of County Commissioners. So when people ask me who's in charge, I default back to the Board of County Commissioners because they establish the agency and then they populate it with individuals serving in the agency. But beyond that, the Board of County Commissioners do not have an active decision-making role apart from a budgetary one. So if there's a recommendation for a certain action that requires an expenditure of funds, it's the Board of County Commissioners that looks for the money to spend, either through grants or other outside funding or through the county's own resources. So it then falls on the Public Health Agency, which is this two-part organization between the health director and the Board of Health. The statutory scheme does not really define with complete particularity who does what, but it's left to for the individual agencies to define somewhat for themselves. For example, the most dramatic use of authority for the Public Health Agency, which is a public health order, and what we've been living through since since the beginning of March, and the establishment of all the requirements within the order, the effect of isolation or quarantine directives. Those are very severe, legally speaking, in that they can be done immediately and can be done by either one of the component parts of the Public Health Agency, and they can be done without any review by any other body. And they can only be done by those two entities within the Public Health Agency. The powers are to a very real degree consistent with each other. So when you look at the overall statute, you look at the statutory scheme of the Public Health Act, you try to figure out, well, who does what and what if there's a conflict kind of thing. The scheme of the statute is to have a kind of cooperative consensus between the director and the Board of Health, so that a health directive or a health order or a protective order like a quarantine or isolation order are moved forward with the participation of both elements of the agency. So you have to then ask you, well, why do we have both and why do they have consistent powers? Well, the director, being a singular individual, is free to act very quickly, I mean immediately. Karen can sign an order right this minute while we're talking, and it is has the effect and force of law and is immediately passed down to law enforcement and is acted upon. So the utility of the director, the beauty of it in the statutory makeup of our Public Health Agency is this immediacy of action, this quick response to something that is of dire consequence to the community in an individual who can head off a problem quicker than any other agency or individual within our political and geographic area. The Board of Health has that same power, but it takes a little bit longer for the board to compose itself, to notice a meeting, to gather and hold a meeting, to discuss a matter, to take a vote, to determine what a direction is. So as a consequence, you have this sort of a sharing of responsibilities. Even though the legal capacity of both entities is the same, the Board of Health tends to, if you look at the statutory intent and then what's implemented throughout the state as well, the Board of Health tends to look at deeper policy issues. In other words, how do we come out of the health order that was entered into quickly? What do we look for? What are the variables? The Board of Health has the time to consider additional factors than the immediacy of a problem that the director has to address quickly. The Board of Health has the luxury of cogitating, if you will, on input from medical advisors and from information sources outside of the jurisdiction, just because there's a lot of information out there. So when you look at the Board of Health and the director, the way they complement each other is to work in concert with one another, one taking the longer view and one taking the more immediate view to deal with the exact same problem and having the exact same methods and power and capacity available to each of them. So it shouldn't be the question of who's the boss kind of a thing. It should be how do we coordinate in the best way, share information, and move the situation forward from a situation of, or from a status of dealing with immediate crisis to now coming out of the crisis and watching for problems that would either set us back or allow us to continue to move forward. So the statute is set up in that manner. The Board of Health is also defined as a lot of you guys are familiar with, as a local public body. So it's very much akin to, elected boards, to city councils or county commissions. It's very much akin to citizen-appointed boards like P&Zs or boards of adjustment or things like that, in that the meeting and processes and deliberations are all done publicly with the ability of the public to participate. Not necessarily to participate vocally in a hearing, but to at least hear and appreciate the debate that might be going on with the board. So the Board of Health then has to conduct itself like any other public body, with a notice meeting, with a record that demonstrates the actions that the board feels is appropriate and what the board considered in order to take those actions. In other words, any evidence, any facts that are brought to the board, which is why you'll hear staff and myself talk from time to time about, well, it's appropriate for you to go out and talk to members of the public, to people who have concerns that are different from, say, the medical community, talking to people who own restaurants or who own small businesses or who are otherwise impacted by the force and effect of actions of the public health agency, but are always going to be looking for a way to get some relief, whereas the flip of the debate is always, well, how do we tighten it down as to put an end to a situation or to a crisis as quickly as possible. So it's important for the board to get input from the community and then bring that input, those factors, those opinions back to the board as a whole. So when you get emails or when somebody grabs you on the street or calls you up in the evening, to pass that on to the group as a whole, not yourself as a conduit, but to feed that back to staff so that staff can compile it and then present it back to the board. It becomes then part of your overall record and then constitutes the factors upon which the entire board can benefit from and learn from and then base their decisions on. So that's the dynamic of the board versus the director, I guess. The things to remember are that the board is looking for a consensus on a long horizon approach to a crisis, and the director is looking for something that has to be done immediate, either an immediate turn to an existing order or the implementation of a new order with new parameters to it. So that complement is just something you have to keep in mind and be aware of each other's limitations and abilities so that you can, serve the public in the best way you can. I guess the other thing that comes up from time to time is how do you do business? So as a local public board member, the individual members have to remember that the board acts as a component part of the health agency, but the individual members that comprise the board are not recognized at all in the statutory scheme. So individually, the board members really are private citizens. It's when the citizens get together as constituted by the BOCC, then the board takes on its character as a functioning body. So don't be surprised when an individual a board member, say, comes to a staff person, says, I need such and such, or would you do this? The individual member doesn't really have the power to direct staff or to do anything. It's the board as a whole. So individual members who have ideas, who think a certain course of conduct is appropriate, you need to bring that to the board so the board can discuss it and then decide what the direction should be for the agency, or contribute to that direction along with the health director. So don't try to assume too much, but don't try to feel that you're not part of an overall solution as well, for individual board members. Let's see, I'm doing a lot of talking. I haven't heard any whispering.
I have a question.
Yeah, Patty, go ahead.
Yeah, John, we've had some glitches in public noticing of Board of Health meetings. The last Board of Health meeting, I looked at the agenda, I was down Valley, the doctor's appointment, but I didn't see anything on the agenda about talking about the next public health mandate. So I felt it wasn't really imperative that I participate because I was, in between in transit, but some decisions were made. So can you please help me with, when we post an agenda and publicly notice a meeting, there's a time frame involved, 24 hours, I would imagine, just like a regular Board of Commissioners meeting. But what do we do when the agenda changes from the time of the posting and the time of the meeting? Because the public was not aware of that.
Well, the law establishes the Board of Health consistent with the terms of any other local public body. So as a consequence, whenever 3 or more of you get together, it's considered a meeting, and it shouldn't be happening unless that meeting was noticed. And like any other local public body, it has to be noticed at least 24 hours in advance. And the noticing is fairly simple. It's just a declaration that a meeting has been set, and it goes on the county's website. The best way to notice the meeting, of course, is to accompany the notice with an agenda, or at least a proposed agenda, not necessarily a final agenda. And the reason for that is simply to make the public aware, or allow the public to be aware of what is to be discussed. If, for example, the construction industry and the effects of a public health order is going to be discussed, then I know a whole set of people who would want to be there, or at least listen to the proceedings if they couldn't actually participate and contribute. If the meeting is going to discuss childcare, then you may have an entirely different group of people who would be showing up. So the agenda is to assist people, members of the public, to tune in, to pay attention, to be aware of something happening, and participate, even if it's just by listening, if they want to. Now, the law does not limit the board to a set agenda once an agenda has been noticed along with the notice for the meeting. And in fact, the notice is being only 24 hours in advance is very quick anyway. So the statute allows that type of flexibility to recognize that things happen. There are dynamic components to the life and the conduct of business for every local public body. So if something comes up, then an agenda can be changed at the beginning of the meeting. If that happens, then typically, or the best practices would be a motion to amend a proposed agenda, or to accept a proposed agenda as changed, and have the body as a whole accept it with those items as enumerated for discussion and potential action. So you can't get away from having the meeting noticed at least 24 hours in advance. There is flexibility in changing the topics for discussion, but to the greatest extent possible, you should try to notice the meeting with an agenda, and have the agenda reflect the expected conversation or expected topics for discussion and action the best you can, so that people who want to be there, who feel they need to be there, who want to participate, can do so.
Thank you for the question, Patty, and John, thank you very much. Is there any other questions? Greg?
Thanks, John. I really appreciate that. One thing that popped into my head while you were speaking was just regarding notification. Does the Board of Health, is there a requirement the Board of Health be notified? Say if staff or public health director has a plan. I know they're working with urgency and immediacy. They issue a directive. What is the protocol just to notify everyone, to make sure everyone is aware of it? You know, this is a new experience for all of us. And I know that when things were changing extremely rapidly a month or two ago, I didn't hear of things until perhaps they were in the newspaper or days after they happened. And I'm just wondering, are there obligations, or is it just kind of wide open? It's just kind of an expectation that the communication lines are open. How does that work?
Well, I guess first I'd mention that the Board of Health is an unusual beastie all to itself. I mean, rather than a steady pace of business throughout the course of every year, so that there's a constant item of business to be addressed, and the level of attention stays at a certain degree uniformly through time, say like a planning and zoning commission, say. The Board of Health exists at a very low profile, as you guys all know, until all hell breaks loose, and then it's the activity level is at the extreme point. So as a consequence, and you all know how local public bodies get together, the more the body gets together and learns to interact with one another, the more you get a feeling for one another's opinions and sensitivities, the better the board works together. So the more you see each other, the more meetings that happen, there's a degree of improvement to be expected in the way business is handled. But the Board of Health is unusual in that regard. Things are very dormant, very relaxed, and then whammo, you're summoned to action quickly. So there's always going to be, I think, this little bit of a stutter step when a crisis happens. You're not used to it. There's a panic. There's a mode. There's a need for immediate response. You have to move, right? So you're going to have things that stick and stop and jump and skip and whatever until there's a smoother running machine. I think that, for example, my observations of the conduct of these meetings, for example, and the interactions that I can see through that and through staff, is that the machine of the public health agency is becoming more and more efficient. The process is becoming refined. Things are coming to be realized. You know, there's a little bit of time for introspection. How do we do this better? What's the thing? So there's that. And to answer your question, Greg, there is no legal requirement for one element of the agency to confer with the other. But if you look at the statute, you look at the title of the Public Health Act in its whole composite, you see that the agency is designed to cooperate between its two component parts. So there's no requirement as to how that communication happens, but it's definitely understood that communication will happen. And perhaps it's as much a function of the personalities of the people who populate the board and the director's office as to how that would happen. But I would assume that in response to an emergency situation, once the action has been taken by a public health director, that there would be, a period where you catch your breath and then you sit down and inform the Board of Health so that everybody's on the same page. There's a period of catch up. And then analysis, introspection. Was this a good action? Do we need to tweak it? Do we hold steady with that? Some type of a more thoughtful sort of consideration than perhaps the director had when he or she had to make an immediate decision to address a crisis.
Thanks for that. That helps a lot. And I think as a case in point, as you point out, communication has improved dramatically. This week's agenda, for instance, I think is very well constructed and plenty of room for interaction and comment. I just want to compliment everyone because clearly the progress is being made. So I want to make sure people understand I'm not criticizing, but I am going to compliment on the progress we've all made on that.
Well, I echo that, Greg. Boy, when we first started getting into this whole COVID crisis, I went, oh my God, how in the heck are we going to be able to pull this together with only 5 staff members? And I do applaud BOCC for making the decision they made relative to funding and staffing. I think it was earlier this week, like Tuesday or something, that I saw come out the next day in the paper. So it's taking everyone working together, and we will have some missteps, but I think the staff is growing, and Karen will be talking about that in a few minutes. Let's just remember to hold each other very kindly in our hearts and continue to work together to really have the best outcome we possibly can for this crisis. So with that, I'm going to turn over to Karen. Good afternoon, Karen.
Hi, thanks. Yeah, and thanks a lot, John, Ely. We really recognize that we truly are in a new space. You know, going from a Board of Health meeting that met quarterly to jumping into a global pandemic and trying to kind of catch our breath to a certain extent. And I think we've had a little bit of an opportunity to a certain extent, I'm not saying it's not frantically paced still, but to really be able to reflect on how to make processes better and how do we work through a pandemic in a different, you know, in a way that we've never had the opportunity to work through that before. So I appreciate everyone's grace on that. And we are really trying to listen to our partners and to the board and the needs of the board around this. And so with that, I do want to take an opportunity to talk through just some bigger level strategic vision components with you all. As John Ely mentioned, you know, the longer view is the view that I find that the Board of Health can really add a tremendous value in, you know, how do we get through this pandemic in the long game, and knowing that we might be in the long game for 2 years. You know, we're really looking at, by the time of vaccines administered, is sort of the end of where we're at, and there's a number of steps that have to go on to get to that stage. And so we were in a sprint, very much so in the very beginning, and I would say a sprint that we maybe didn't have all the resources to be in that sprint to begin with. You know, as Marky said, we were starting with a staff of 5 going into the pandemic. And now we're in this marathon and we're trying to figure out, you know, where are the aid stations on the way? How can we share the aid stations for the community on the way so that they know where there's the lights in the tunnel, maybe not totally the light at the end of the tunnel. And really trying to figure out how do we sustain for the long term around this. And that includes organizational infrastructure, but it includes this strategy as well. And so that's what I want to spend some time with you all today around. And you've seen these goals before, but we've never had an opportunity to actually talk about them. And so I wanted to share these goals with you, have a dialogue and discussion to see, are these the right goals still from your perspective? Are we missing anything as we start to create this long-term strategy around this response and recovery is how we're looking at it. And with that, Lindsay, I'm wondering if you can bring up the slides, or do you need me to drive them? Thank you. And this is just, we haven't really talked about the mission of the department or our vision or our equity statement, but I do want to lead in on this so that we can be reminded of really what the goals of public health are overarchingly, and that they're really truly around promoting health. So that's encouraging healthy behaviors, preventing disease, which is what we're doing right now with COVID-19, and protecting the population's health. And that could include things like the public health order really is a protection around preventing disease and protecting people from getting sick. That we're really looking at a sustained, healthy and thriving community. That's always our goal. And to really all kind of riff off of what Kim said earlier to talk about, what does health equity mean for our community? And we based our department on health equity. This is a core value of our department and of the folks that work for the department. We hire based on people kind of coming in on board with a health equity lens. And really, how do we get to this space, especially around COVID-19, that we recognize, we haven't been able to engage the community very well in this response because of the critical and kind of crisis nature of it, and really wanting to move back into our core value of equity. And that includes engagement with the community and engaging and listening to people, and designing solutions together and not just on our own. So I just wanted to bring that to light again, because this is important to our department. Lindsay, you can, next slide. And this is, to reflect on what Kim just said. And truly, we believe that systemic racism is a public health issue. And I just wanted to share a statement about the juxtaposition between social justice and public health. And in fact, public health is rooted in social justice. It's a core value of public health professionals and the public health discipline. And to just share a little bit about our perspective as a public health discipline, and then some information to share with you about our perspective as a department around this. And I think it's kind of this interesting thing this week, it really truly is like a heartbreaking week to think that we surpassed 100,000 deaths, COVID deaths in our country. And then we also had the death of George Floyd, or I think his friends refer to him as Floyd, just Floyd. It is really an appalling consequence of what we in the public health community know all too well, and that's the reality that people of color are confronted with every day. And to reiterate what Kim said, racism really is a public health issue. And we see that systemic issues that people of color face through the legacy of slavery and discrimination that lead to really social determinants of health, which prematurely end lives. We can look to disparities in healthcare, in pollution exposure, and access to green spaces, nutritious food, educational opportunities that have long harmed people's health. And that is really true for people in marginalized populations. And what I think COVID-19 has done for us is it's just surfaced that all, laid it bare for us to see. And as Kim mentioned, we know that COVID-19 is disproportionately impacting people of color right now and older adults. And that really all of us have this responsibility to address systemic issues within our country and injustices within our country. And so we are, as a department, dedicated to our mission and our vision. We're dedicated to our values of equity and justice and inclusion. And we met this morning and came up with our commitments to this community around that, those values. And so we wanted to just share these with you all quickly, and know that there may be an opportunity for the Board of Health to make a statement as well. And it doesn't obviously have to be today, but to invite you into this commitment that we are making. So Lindsay, if you can do the next slide. So this was generated by the department. So these are all members of the department that, and actually a couple other folks within Community Health Services were involved in this. So that we acknowledge our individual places of privilege, and we're going to work to disseminate those systems of oppression that exist, that we will be self-compassionate and compassionate toward others, that we will model by living our lives as vessels of kindness and hope, that we will educate ourselves on systemic issues of racism and other isms, and don't expect that people that are in marginalized populations, that's their job to do for us. We will listen to people of color and other marginalized communities and advocate for those who have been silenced. We will meet people where they are and celebrate their differences. We'll have patience and grace and assume positive intent. This sort of came out just what Greg was saying and Marky was saying. We will provide culturally appropriate communication, inclusive people first language and translation through this incident. We'll support barrier-free COVID testing and equal access to testing facilities at no or low cost tests. That will work within our own organization to address practices which don't promote inclusion. And collectively, we will continue to fight for equity and justice every day. And we as a department have committed to these as we move forward. And I just want to open it up for the board if you have any comments about those.
Thank you very, very much, Karen. And I want to thank the department for spending some time this morning putting those together. I find them very, very inspiring personally, and I find them covering the massive amount of work we have in front of us in addressing social inequity and justice. So I'll see if other people have some comments. Yeah, Ann?
Yeah, thank you, Karen, and thanks to your staff and the other people that worked on that. One of the things that I've said repeatedly through this, and everybody knows this, it's really exposed the inequities, the weaknesses, the vulnerabilities in our society. With society, it's also exposed some interesting things in terms of climate change. There are a lot of lessons to be learned from this COVID, and my greatest hope is that we don't go back to normal and forget everything that we've learned or begun to learn during this.
Totally agree with you, Ann. Wow. Powerful amount of, powerful, Karen, it was just powerful. So thank you very much. And I'd like to pick these up on our next agenda so we can really spend the time as a board and really begin to look at how are we going to do all of this hard work and how do we engage? Patty, I see your hand going up.
Yeah, I agree. It needs a broader, more equitable, in-depth discussion. So Karen, if you could send us just those two slides, just send it to us separately. I'm one that keeps a file. I'm still on the paper generation. So that way I can really digest it and make my comments and be ready for a discussion in the future. So thank you. Thank you for the time, energy, and compassion.
Okay, anyone else? If not, we're going to move on. Greg, did you have your hand up?
Yeah, thanks. Very briefly, I want to echo what Patty just said. Karen, that was great. It's very helpful to frame the long view, and I really appreciate it. I've been thinking a lot about this with our response. We had the sheriff on Tuesday talking about the letter, the joint letter from the various law enforcement, and we certainly backed them up at the county commission level. My kids joined a march yesterday, and we've been trying to figure out, how can we, with people of such privilege living in the mountains in Colorado, really, what dare we say, what can we say, how can we contribute to this somehow? And I just wanted to point out, Aspen has an interesting history, going back to the mining days, or even before, to the settling of Aspen. Very briefly, the first settlers here ran the Utes out. And it was not a pretty sight. There were Chinese railroad workers who came here and were part of our community, launderers, people running businesses who were run out of town back around in the 1890s. There were factions with immigrant miners, the Irish against the Swedes, and you name it. There were factions that were arguing, fighting, and discriminating against each other. After World War II, we certainly had fear and discrimination against people from Germanic backgrounds coming into our community. You name it, it exists. Up to the hippies and the beatniks who were not appreciated when they first hit town, or even the snowboarders more recently. You can get carried away with who's getting discriminated against. But the point is, it does happen in a place like this. It happens here. We're not all immune to it, and it just helps me gain some context on my perspective on it. When I think about that, in our own community, going back 100+ years, we could always, if we look hard enough, we can easily find evidence. So this just underscores to me how important this is, and I really appreciate you bringing it back to us.
Thank you very much. We're going to move on in the agenda. Back to you, Karen. You want to talk about what it takes to build out a department during a pandemic?
Yeah, sorry. And I actually was going to just go through the goals, but I think I can wrap the other part into the goals so that I can
Okay.
part of my section today.
Let me tell you, she's been working her butt off, guys. Midnight, every night. So go ahead, Karen.
Okay, Lindsay, can you pop those back up? Thank you. Great. So this, again, you've seen most of these goals. I think we added a couple more when we did the presentation to the City Council. But so you haven't seen all of them, but I just want to go through these and make sure that these are the right goals. I won't go into too much detail on the initial ones because you have seen them. But I might just stop and pause for each and say, is this still what our right goal is? And then we'll see if we're missing anything. So again, just to really slow that transmission of SARS-CoV-2 throughout the population or through the population and really keep the number of infected folks and within the capacity of the healthcare system. That's the flattening the curve, and that's really protecting our infrastructure. So Marky, I don't know how we want to do this. If maybe I'll just go through them all and just say, are these the right ones?
Yeah, let's do that. That'll save a little time. So go ahead.
Yeah. So again, we've been preparing for a surge in the healthcare system, and ABH has been a leader in that, but we've also been working outside of the ABH system just to think about alternate care sites and mass casualty planning, and just thinking about that kind of bigger picture around the healthcare system, making sure that there's enough PPE for a sustained response. If there was a surge, making sure there's enough PPE for testing. And so that's all been work that we've been doing since, for a while now, I guess. I don't even know how many months now. So that's been a process that's been going on. You can do the next one, Lindsay. And then this is getting at what folks have mentioned earlier. Kim mentioned this and Charlie mentioned it, of really, we're even more so, we're starting to see that folks are more at risk for COVID-19, and thinking about that protection of folks as we move forward through this response, whether it's the social distancing or really just thinking about access to care. Knowing that there are specific populations that are just more vulnerable to severe disease or and mortality. And again, this is the work that's happening sort of on the, not necessarily within public health, but we're certainly working with partners that are really leading this effort. So that includes human services and other nonprofits in the community, really to mitigate the impacts of the social and economic disruption that we're all very clearly aware of now. Next slide. Oh, maybe I skipped over number 5, but I think I pulled number 5 out. So number 5 is actually building the infrastructure for a long-term response for this, and that I will talk about what we've been doing in the public health department to build for that long-term infrastructure, but I'll get back to that later. So I'll jump to number 6. Again, we feel like we're not really in a place to be done until not only are there antivirals and vaccines, but they're actually distributed. So it's not just getting the vaccines, but actually making sure people have access to them, equitable access to vaccines, that people have that ability to get them, and that they're in essence long-term effective, we're hoping for. So that will be part of our response at some point in this community. Next slide. And then this is getting at what Anne was saying. I think Tori's talked about this, Greg, that this is sort of that visionary piece of how do we look at, looking at our future differently. I keep saying, I don't want to go back. I don't want a new normal. I want a new not normal. I want to look at the world differently, because what we've seen with George Floyd and other things, right? There are systemic things that I think we can do better. And so how do we collectively reimagine a future outside of COVID, on the other end of COVID, that we look at what works best for our community's health, both physical and mental health, social and economic resilience, and really getting at that resilience piece. And I know there are some amazing visionaries in this community that could start this dialogue, or probably have started this dialogue. And really, I think this is where it gives me hope, active hope for the future, that we don't go back to what happened, what got us into this to begin with. Pandemics, we know, are going to be, as Anne was alluding to, with climate change, we're anticipating more epidemics. We're anticipating this kind of thing to happen more often. And so how do we look at that intersection of social justice and climate justice and climate change and pandemics, public health, and look at a better future for all of ourselves and our children, and the youth of tomorrow that are out protesting yesterday. That's who we're building this better future for. And so I just want to kind of keep that as an aspirational goal. And so here I do want to go back to the goal 5. So we are looking at, we have to change our infrastructure to maintain this long-term sustainable response. And again, to Marky's point, we really thank the Board of County Commissioners for recognizing that we have to build a new army of contact tracers and a new army of consumer protection folks to really be able to do this and do this well. The better we do at public health, and Tori said this, like the better we do at public health, the more we can promote our community as a safer community to come to. It goes hand in hand, and the public health piece has to come first. But I truly believe that if we can build the infrastructure that's needed so that we can box it in and have consumer protection and have this rolling opening, phased opening response, that we're giving our community a chance to have a long-term recovery that's really strong. The research out there, preprint research right now, is saying that if you do a more measured response, or a more measured kind of reopening and a more measured way of getting systems in place, that actually your long-term recovery is better. Long-term economic recovery is better. And so I just think we are being very thoughtful in this community about how this goes forward. And so we needed the infrastructure to make that happen. Next slide. So this is just, the orange was the existing department before COVID. And all of these people had jobs that had nothing to do with COVID, pretty much, before this happened. We have one person that was Carlin, our epidemiologist / EPR coordinator, who is probably the only person sort of doing any work that would naturally fit into this structure. And as I mentioned the other day, she's been out on maternity leave pretty much the whole time we've been in response. So we lost her expertise really quickly. But what you see in blue are all the positions that we're building out. So for our tiny little department, we're growing very, very quickly, very, very fast. And that's a lot of work to be able to get these folks in place, to get them in place quickly, to onboard them, to, everything from the hiring to bringing them on board is pretty substantial. And when you think about the infrastructure that we have for our team to really be able to do that, we have a lot of support from county HR and other county departments, but there's still a lift for my team. And so when you hear that, we have a lot of work to do, we are really, really doing a ton of back end work that I think maybe people just aren't as aware of. And that also, is reflective of our ability to engage in our community or engage with others as effectively as we would like, because we have a lot of back end work that we're doing. So I just wanted you to kind of know what we're doing to build out the department now that we have the FTE approval, and how that's going to really be able to protect our community and make it a safer place to be in the long term. So this is a lot of heavy lift, like I said, from my team, and they're doing an amazing job on all of this work. So there's that. So there are the goals. Please, this is where I want your total participation of, are they the right goals? Anything we're missing?
Any questions? Karen, are all those blue spots hired?
Um, no. So there we had two existing folks that we brought in. Justine, who's been doing some data analysis for us, and we want to keep her on. She's awesome. So she's going to fill one of those blue spots. And then we did hire a temporary epi because Carlin was out and Charlie is probably going to be leaving us soon. So that position is filled. So two of the blues are filled, but the rest are all to be hired.
You can see there's a lot of work ahead for Karen and the department. So Karen, if there's anything we can do to help you out, please let us know. Everybody's shaking their head yes. It's very, very important that we have what I call the A++ Department of Public Health. This community deserves it, and we've got the right leadership, and the staff that we currently have, awesome, just really great and very diligent. And I see Greg is raising his hand.
I just wanted to make a brief comment. Last fall, when we were doing our budgeting, we understood that the state was recommending that we actually hire something like 11 new public health employees. And pre-COVID, I think the Board of Commissioners was, of course, in shock. That represents a huge hire for us. And so we went back to Karen and said, sorry, you can't do that. And ever since then, post-COVID, I've been contemplating that and realizing that maybe they were prescient. I know we've been very careful in allotting the budget and asking if we can transition people from within the county. So I just want the public to understand that this is something the state has recommended to us months ago, and that we've also been extremely careful and keeping the perspective that, if we have to lay people off, we don't want to make a bunch of new hires going into a recession, but in this case, we have to. So it's been a tough choice, and we've had a lot of conversation about it. But I did want to say the state had recommended that this was, I don't know if it's a mandate or not, you can tell me, but that still resonates with me because we turned you down last fall, and here we are needing them now. Thanks.
Well, and yeah, thanks for that, Greg. And I think there is a bigger story here, and it's not there's a bigger story of the public health system in the country not being funded as well as it should. CDC has seen drastic funding cuts for the last 10 years. I was actually in Washington, D.C. Advocating for a 22% increase to the CDC by 2022, right when kind of COVID was becoming a community spread in the nation. And I think what we're learning is that that kind of gutting of the public health system to a certain extent in the nation has come back to impact us. So it's not a local, necessarily a local concern, but we did find that to be to be right sized last year, it was recommended that we get to 12 to 16 FTE. That we figured 12 would make the most sense. So that was our request pre-COVID. So that was a total of 12. So we were going in with 8 and maybe getting up to 12. So I do think that, but that's just a product of federal cuts, state cuts, the local public health system across the nation has been underfunded for way too long. And I think that's just where we are now. So I do really, truly appreciate the community's recognition that this is going to help us to get through this, that staffing is critical to make this, again, this community as safe as it can be and to really get out on the other side of this.
I think we lost Marky. Greg, do you want to step in as co-chair?
I was going to say, Greg.
Wow, that just occurred to me at the same time it occurred to you. Okay, if Marky has dropped off for one reason or another, I can keep us going here. Karen, what's next? Are we ready to move on? Any
Yeah,
other
and
questions?
I guess if there's, you know, if there are any comments about, are those the right goals? If you want to, you know, just do a thumbs up, thumbs to the side, or no, and then is there anything missing? Okay. And nothing missing? I don't hear anyone piping.
Yeah, if anybody, I guess I can't see everyone. I don't have the admin thing here. So if somebody has to speak up, please go ahead and we'll sort it out. But it sounds as if we've got a thumbs up. Is that nods of heads would help as I scroll through all the pictures. I think we're doing okay. Linda, is that a question from you?
Yes, I was wondering, Karen, about being proactive as far as when and if the immunization does come about, as far as kind of being proactive and deciding where the clinics would be, because I think we're going to have an immense response in gathering people that can volunteer to immunize and having a list and all of the above.
Yeah, absolutely, Linda. And I feel like that is the gift that we have now, is that we can start planning today for that. So there is some work, and in fact, Liz is a part of that, Liz Stark. And I will be kind of having a convening of that to start to plan through that process, because now we do have a little bit of time to figure it out.
Great. Okay. I don't see any other questions from our board. I may be missing. If so, Marky's back. Marky, I'm going to hand this back to you now. You're muted though.
Nothing like a server going out right as we're doing the meeting. Karen, I apologize for having my computer just freeze up. So are we ready to go into the roadmap to reopen? Or okay, is Kara there?
Mm-hmm. She is.
Let's do that.
And I was just going to preface this for Kara going in. So what we really want to do, and we also recognize we want to leave some space to get that feedback from the board,
Yes.
as Billy mentioned too. So, you know, Kara, if we can, there's not a lot that Kara can cut out, but we do want to get to that space too. So with that, what we really want is to talk about our process that we've been using around the phases of the phase. So, you know, think about phase 2, and then we've done these rolling mini phases through that. And we're going to recommend, and we would like your opinion on, is that an appropriate methodology for phase 3? The medical advisory team, public health, our sector folks, we're getting a lot of good feedback from agency admin that rolling kind of process is working well. And we'll tell you why we think it's a good process. But really what we want to get from you today is, you know, what your understanding of the process. Do you feel like that's the right process? Are we missing anything? And a recommendation that we would use that process for phase 3 when the data is ready to get us to phase 3. Kara, is that a good enough lead in?
Yeah, and I think you helped skip over a couple slides. So I'll make this quick to make sure you guys all have time for feedback. So. So again, I'm just going to reiterate for the board and even more so for the community that moving forward, each of these rolling measured approaches within the phase is all based on our community's ability to maintaining the 5 commitments, and that really together we're keeping our community safer, and that we're keeping our community open with this slower measured approach by us all keeping these 5 commitments at the forefront in any of the activities, which has been hit upon throughout the meeting, but to continue to remind ourselves and our friends and family and community of them. So as Karen mentioned, with this phase approach, it really is based on this risk matrix. It's based on it for the business liaison and consumer protection group, and really thinking about what are those number of contacts and that contact intensity, and how do we start to use these rolling openings, knowing this risk matrix and what it means for increased exposure. So with that, as we think about the roadmap, it's also really important to also remember all of these dates. It's our best attempt. I think Anne hit it before of we want a solid answer, but it is still our best attempt. It's all going to be based on the data. It's going to be based on maintaining these 5 criteria before we're able to really move forward. And so if we see any changes, we'll have to pull back. But we recognize that the community, and especially those sectors that are opening, we all are looking for those dates and some level of certainty in this world of uncertainty. And so really what Karen prefaced and what we want to talk to you all about, is this phase 2 reopening and what it means looking into phase 3. So as hopefully everyone is aware, on Monday, we had summer day camps open, outdoor recreation, and ski areas with approved COVID plans. We're working with SkiCo right now on what those rolling phases look like. As of tomorrow, places of worship are able to open with guidance. On Monday, we'll have gym and fitness centers, recreation centers, pools, and organized recreational sports. And again, a lot of this is all based on that risk matrix, those high contact and contact intensity, and where is that increasing? And that's how we're doing this phased approach. So we know that events and gathering size is going to be one of the biggest tests for our community. And so that is pushed to June 15th. We'll increase the gathering size to 50. We're also working on revisiting what is the public transportation capacity and as well as theaters. And then on June 22nd, we'll be revisiting the short-term rentals that are not professionally managed. That really encapsulates phase 2. What we would like to discuss with you today is looking ahead and thinking about those 5 criteria. The 4 weeks out really puts us at that June 25th timeframe. It's 4 weeks from the first opening of phase 2, which was the restaurants and lodging, and being able to come back to the Board of Health with recommendations from the medical advisory team, getting feedback from the various sectors in the community, and then the public health expertise of reviewing all the data and recommendations to then start evaluating what does a rolling phase 3 timeline really look like. And that we would be able to have that data for the Board of Health to review and consider at that June 25th Board of Health meeting. And that's really the crux of it. I'm going to leave the time for feedback and the Board of Health discussion.
Okay. Okay, any questions here? Any comments? Seems to me like it's going fast, but I guess it's the best way to get the community open. Any questions, thoughts, comments?
I guess I just asked the board, does that the rolling nature of that, you know, we're giving space for the guidance to be created. We're giving some space to have more of this step-by-step approach. So it's not just this free kind of big opening right away, that we have time for the data to sort of respond and to have a more measured kind of phase within the phase approach. Yeah, Kim, or do you want to say something?
Kim, you have your hand up.
I just wanted to say, Kara, thank you for outlining that so well. And the medical advisory team does support this phase within a phase. I think the public health department in combination with Kara and her department has really done an amazing job with doing this. And I know a lot of other public health departments and counties are not doing it this way, and it's just one big opening. So I really applaud you in terms of these small incremental steps.
A question for you, Karen. In terms of our opening and the phased approach, which to me makes so much sense, what are other counties doing? Are they pretty much in step with Pickens County on rolling, or I've heard other things from other elected officials. They seem to be like, let's open.
Yeah, and so what's interesting is, so we took that roadmap to reopening, I think I mentioned a long time ago, from Resolve to Save Lives, which is, run by former CDC Director Dr. Frieden, brilliant people there. And, that roadmap to reopening was something that they had crafted, and then we, in essence, adopted for our community. Not all counties in Colorado have done that. And Washington State, they've done it at the state level. So they have a roadmap to reopening with phases for the whole state, blankets the whole state. The state of Colorado has chosen to do more of this social distancing modeling that Charlie talked about. And they don't have a roadmap to reopening as the state. So what you're seeing is like different counties are doing different things based on where they are as a county. Eagle County has adopted a roadmap to reopening as well, and you're probably more familiar with that. They are moving through their roadmap to reopening, not in that phased approach, as far as I understand. They're doing more of they're just looking at the phase 1, phase 2, phase 3, and opening sort of at that level rather than the rolling phases. And Kara, you've been in touch with them, but that's my understanding.
She is shaking her head yes. So is there anyone that thinks we ought to go faster, slower, or is everybody pretty comfortable with this rolling model? Let's see. Yeah, I think everybody's kind of shaking their heads. Yeah, it does make sense. Tori has an observation here.
Yeah, I appreciate it. Thank you very much. Karen, thank you, of course, for the work that you've been doing, and the whole team as well. What's been interesting about our phased approach, and something that may be yet to come and can be implemented maybe as we go forward, is it's been very difficult, I think, for people to get the guidelines that go along with these openings. We have overriding guidelines from the state, and then we are kind of phasing in different items. And so I'm just wondering about, as we move forward, about getting that information out to people. Let's see, I think I saw something there, for example, gyms are supposed to open at some capacity with distancing, I'm assuming, and such, on the 8th. And so I'm just wondering how we can, as we are rolling out these new openings and new opportunities, how we can really kind of have a clearinghouse or consolidation of the guidelines that are supposed to be being followed, and how we can get that information to the public.
Yeah, Tori, thank you for bringing that up. I think that's a really important point, and has been, I know, a tough piece for all the different sectors. One thing that we've been able to do now with this phase within a phase is having a commitment that all the guidances will be up and finalized by Friday mornings before those Monday openings. So that's the commitment we're making to all the working groups we're working with. For example, places of worship is a little bit difficult because we're waiting on state guidance, which has not been finalized today, but we've been sharing the drafts. And so as we look within each of these weeks before those sectors open up, we're working with the working groups, trying to get feedback so we know what's coming, and then have a commitment that Friday before it opens, it will all be up on the website, shared throughout those working groups, so they have a couple days advance notice. In the perfect world, we'd love to get to a week or 10 days, and maybe we'll get to a cadence to get there. So right now, we're just hoping that 4 days is a place that, knowing that we've been working with them on the front end.
Thank you very much. Okay, I think we have a lot of support for the rolling going forward, Karen, and obviously we're going to have to really watch our data and be attuned to all the data. I'm going to move on, if that's fine. My 13 minutes that are left, we're not going to get through the whole agenda, but I want to talk about the frequency of board meetings. And I know we committed to weekly, which really creates a huge challenge for staff to put together an agenda. It takes about a day and a half to pull together all the data, do all the slides and what have you. So I would like us to recognize there's still so much work to do in terms of hiring staff, and for Kara to do the work that she is doing. Maybe we slow down the frequency of meetings and go every 2 weeks. Or we could wait to go to the 25th of June, but I almost feel we've got to spend some time 2 weeks from now talking about what we're not going to get to, which is community comments. I think we need to have a good, solid board discussion. So I want to get feedback as frequencies of our board meetings. Any comments from the board? I don't see any hands go. Yes, Jeannie?
I think every 2 weeks is fine, or when something happens and we need to make decisions, that may be a better use of the time of the board as well as the public health professionals. So I think we don't have to have a set time unless it's better for other people's schedules where they can put it in.
Well, my thought was let's get it every 2 weeks and put it on the agenda.
Mm-hmm.
And I have the ability to cancel a meeting if there's really no agenda. But I've identified 2 items. One would be the goals discussion. Again, I think that was very, very important to look at the issues, particularly around social justice. And the other, if you will, to spend some time talking about what we're hearing from the community. And with that, I saw Patty Clapper's hand go up.
Yeah, I agree with every 2 weeks, but I think we should also keep it in mind to kind of keep that Thursday slot open on the alternate weeks, just in case something comes up or we have a change and we need to address it quickly, just so we have that time kind of in the back of our minds that we still may need to come to a special BoH meeting.
Okay, if we want to do that, we can put it on the calendar, pencil it in on your calendar, and I'll confirm with Karen prior to Thursday, probably by Monday. She and I usually talk several times a week. So I'll let you know which way we're going to go. Okay? Yeah, Greg?
I just wanted to make sure if everyone has had a chance to weigh in on it. It was important to me to have the regularly scheduled meetings. Even if the meeting's 5 minutes long, it seemed to me that it would be valuable for those who do have schedules and try to keep things on a regularly scheduled time frame. So I guess going to 2 weeks probably isn't a bad thing, but say we have a spike and things start happening fast and furious in August, are we going back to weekly meetings then? Right now things are calm. We're kind of between the rapids on this river. If we go back into tumultuous times, are we going to be needing weekly meetings again? So I like the idea of keeping it open on the schedule, but maybe every 2 weeks is fine. It certainly is important. I also wanted to say, I think it's possible the Board of Health could have a meeting without all the necessary prep time on the part of Karen and her staff. I think that there might be a way that board members could get together and have some of these discussions without the necessity of the lengthy preparation on part of staff, is what I'm trying to say. And I wanted to put that forward because I don't know if other people have burning issues they want to discuss. I certainly don't at this point, but it'd be nice to make sure everyone who has something is able to bring it up and discuss it. And that shouldn't require a day and a half of prep from anyone. So my alternative suggestion is, we keep it weekly and you check in, and if it's only a 5-minute conversation, that's fine, but it's there, it's on the calendar, and it's something we do. But we've got 2 votes to go to bi-monthly. I'll go along with that if everyone else does.
Yeah, Patty?
Greg, you and I talked about that before, but I think still penciling in the every other Thursday keeps that opportunity available if something comes up. So I think we're covering it in all directions.
Yeah, what we were hoping to be able to do is do the public health board meeting on, like today. Next week would be the community conversation. And so So that's one way we can keep the community fully engaged. And that's very important. So that's kind of the pace and rhythm that I've been working on with Karen, her staff, and with Phyllis, just trying to not make everything so urgent, because I think we're starting to get a handle on how to do this and do it very effectively. So let's keep it penciled. You're going to hear from me before Wednesday whether or not there's going to be a meeting. Okay? Okay. All in support? I mean, just raise your. Okay, that's what we're going to do. Now we're supposed to have a discussion about what you're hearing in the community, and I see it's 3:23, and I'm just going to bring up one item that I'm hearing about in the community. And this was the restaurant / kind of bar that had a lot of people. And where are we, and what's the plan on dealing with this type of situation? I'm concerned that could happen at almost any restaurant. Who wants to weigh in?
Well, I can start, but I don't have a bunch of information. I know that we are trying to work with the county when it comes to enforcement and compliance issues. And that actually leads me into the question that I had, that what I've been hearing is exactly that, about enforcement and compliance. I think on the chart that Karen was showing about building the response team, there were 2 positions for consumer protection. And I'm wondering if those are positions that are somewhat related to this issue.
Can I jump in and address Tori's question? Yeah, so Tori, the consumer protection positions, we think of very similarly to like a food program, a retail food program. And so if you think about what retail food inspectors do, is they do a lot of education. So they go into the establishment and, look around and give some good education to the owner or the manager of the restaurant, the employees. They might do some, in essence, some kind of inspection with that. And then there is, if they start to see a lot of, I guess, sort of violations, there's a compliance component to that. And so thinking through this, and I will have John Ely weigh in on this as well. But we're envisioning that position to be very much like that, but around COVID. So they might be going into a retail store, not just a restaurant, and really allowing them, it really is truly an education first kind of model of helping these businesses, answering their questions, supporting them in meeting the expectations around the guidelines, and that the compliance piece would probably come, in conjunction with talking with law enforcement or the attorney's office. That and John, please do weigh in on this, but it really will be like a food inspection model to a certain extent, but there's not as many statutory pieces to this. It's something that we're truly creating a new program on the fly for this.
I guess I never thought of it as a food enforcement model. My introduction to the community about 100 years ago was through law enforcement. So I guess the model I tend to look at is the Pickens County Sheriff and the Aspen PD and Snowmass PD. The other thing to keep in mind is that you're dealing with enforcement of a public health order, which is an interesting document. They tend to be long. They can be complicated. They change frequently. So it's like you have to forgive somebody a little bit if they're out of line. So the first contact is, as Karen said, an educational one, and then a follow-up to make sure that what has been explained and what has ostensibly been understood is now part of operations and part of compliance. If you're dealing with somebody who's just obstinate, which is rare, then quite frankly, we're simply prepared to launch into a full enforcement rigor. If it's a business, if it takes on one type of profile, if it's an individual that takes a different type of profile, depending on what the circumstances are, it might be a criminal enforcement, which we have only one since the COVID crisis began, or it might be a civil enforcement, which would involve injunctive relief to either compel action or to prohibit action with the force of a court order layered on top of the health order, in the force of more immediate sanctions coming from the court. And we've come close to doing that a few times now, but have not needed to do it ultimately, at least not yet. If it's a business that involves reliance on any other type of license or local government approval, then the anticipation is to work with the local jurisdiction, if it's someone other than the county, to evaluate whether or not the license should be examined and possible sanctions through the local jurisdiction, revocation or suspension. So, you know, being prepared to come down hard on a violation with somebody who's recalcitrant, but the initial response always being one towards a educational type of an attitude and a more understanding of the circumstances that someone might be in and what led to a non-compliance situation.
Thank you. I'm looking at the time, so let's look at 2 weeks from now and make sure we get this issue, other issues that are coming forward. I've got a lot of questions coming from community, from part-time homeowners who are coming back, et cetera. So I really want to honor each one of you. You're all working very, very hard, and this whole notion of community service and servant leadership, that is what we're dealing with in terms of taking care of our community. So with that, I'll ask if anyone is willing to put forth a motion to adjourn.
So moved.
Thank you, Tori. Do I have a second? Just raise your hand.
I'll second it.
Thank you, Jeannie. Okay, any further discussion?
Is it possible for any other items, questions, and things that we hear from the community? Is there somewhere that we should send those to either get answers to questions or to share some of the input and feedback we've gotten from our respective boards as well as our citizens?
I would suggest we could send those to Karen, who can dole them out to her staff, but copy myself, because we're working through all the questions. And we're behind the scenes, and I'll do respect to everyone in your time. We're trying to get into a rhythm of I do the board agenda now. So, discuss that with Karen and Phyllis. We spend quite a bit of time on it just to make sure we've got the best agenda. And if those questions, Tori, that you're talking about, if you can funnel some of those over to myself as well as Karen, that's really going to help in terms of communication.
Will do. Thank you.
Okay, all in support of adjourning the agenda. Karen, did you want to say something? Okay.
Yeah, so maybe we can set up a form or something so that that can be more easily fed to us. So we'll figure that out.
Okay, all in support, raise your hand.
Aye.
Okay, meeting's adjourned.
Thank you all.
Thank you.
Great meeting today.
Yeah. Thank you very much. Thanks for all the work.